Most of the time, the inflammatory bowel disease is related to the medical therapy, and most of the time it's treated with a good medical therapy by combining the steroids and monoclonal antibodies and immunomodulating agents. And you have to give a loading dose with the steroids, and then you have to put the patient on proper maintenance therapy with the monoclonal antibodies and immunomodulatory agents. Now, there are some indications for surgery which basically are related to most of the time to the complications. When there are complications developed in case of the Crohn disease, you do not have any other option other than going for surgery. And then after the surgery, for the recurrent disease or for the prevention of remission and relapse, again, you have to put the patient on a medical therapy. So there are a few indications for surgery which should be in the back of your mind before treating any patient with a surgical complications. So the first and the foremost important thing is the recurrent intestinal obstruction. If the patient is a known case of Crohn disease and he is chronically coming to you and reportedly have multiple presentations for the recurrent intestinal obstructions, then maybe possible the patient has developed a stricture, and for that the surgery is the indication. Then persistent or rarely massive acute bleeding. Sometimes it's possible that as a result of the Crohn disease, there's ulceration, and that ulcer is actually persistently bleeding. So the persistent or rarely massive acute bleeding is one of the indication for surgery. I have already discussed that most of the time the ileum, in 70% of the cases, ileum is being affected by the Crohn disease, so especially the terminal ileum. So the patient can actually present to you with a terminal ileitis or ileal mass, or the patient can present to you with a perforation of the ileum. So the perforation of the ileum can actually present to you with the patient can have a presentation of localized peritonitis or generalized peritonitis. And because of the peritonitis, the patient can actually suffer sepsis, and you have to avoid the sepsis. For that, free perforation of the bowel, whatever the segment is, but most commonly it's the terminal ileum, so you have to go for surgery. Then, if the patient has been for a regular medical therapy for a very long time, and there is no response to the medical therapy, then obviously you have to put the patient prepare the patient for surgery if there's a failure to the medical therapy. Then there can be, the use of the steroid, although is beneficial in case of the Crohn disease or other inflammatory bowel diseases, but still there can be steroid dependent disease, and in that obviously you cannot put the patient on a medical therapy, and then you have to go for surgery. Intestinal fistula has already been discussed because there is a thickening of the wall, and because of the thickening, obviously there are multiple fistulas that can be formed, like there can be ileal vesical fistula, or there can be enterocutaneous fistulas, there can be ileocolic fistula, or there can be fistula with the posterior wall of the vagina, which is basically the rectovaginal fistulas. So these fistulas are absolute indication for surgery. So sometimes the patient can present to you with the diseases of the anal canal, like there is a perianal abscess formation, there's a perianal fistula secondarily to the Crohn disease, or there is sepsis of the anal canal. So obviously you have to go for the percutaneous drainage, and if the fistula is there, then you have to go for fistulectomy or placement of the ketone. That would be another indication for surgery. The perianal diseases can be, it can you can get confused between hidradenitis suppurativa because there can be mucocutaneous ulcerations, and then you have to look for perianal abscesses, perianal fistulas, sometimes extensive, if there's extensive disease of anal canal and the patient is repeatedly reporting to you with a proctitis, then you have to perform the proctectomy, and that would be another indication for surgery, especially the perianal diseases. And we know that these inflammatory bowel disease, especially when we talk about the Crohn disease, it's known for its malignant potential. So if there is any focus of malignant change in case of the Crohn disease, then you have to go for surgery. So remember, if there are no complications and the patient is responsive to the medical therapy, then you can manage the patient lifelong on the medical therapy. And there are a few strategies for that. We'll be discussing the top down, upside down, and downside up treatment and management options and techniques. But if there are complications of the Crohn disease, then you have to go for the surgery. So remember, the indications are recurrent intestinal obstruction, is if there is a massive acute bleed, or there's a persistent bleeding and the patient is presenting to you with severe anemia, or there's a free perforation of the bowel, there's a failure to the medical therapy, there are intestinal fistulas, there is a perianal disease, or there is a potential for a malignant change, or there's a focus of a malignant change, then you have to go for surgery. Now, when we talk about the medical treatment, there are two approaches which are basically followed. One is the top-down approach, and other is the top-up approach. Like you try to start from very simple medications, and then you progressively you add on the complicated and complex therapies like the immunomodulators and the monoclonal antibodies, because obviously these monoclonal antibodies and immunomodulatory agents, they have their own risks. Especially when you talk about the monoclonal antibodies, they're most of the time they are again causing a lot of immunosuppression. So both strategies are available, and the research has shown good prognosis with both of the management techniques. So when you talk about the step-up therapy, so what you do is you start from a very basic drugs, and you keep on building. Like you start from the steroids. Most of the time steroids are not used for a maintenance therapy, but you try to manage the acute episode with the steroids, and then you put the patient on maintenance therapy for immunomodulatory agents, anti-tumor necrotic, anti-TNF factors, and monoclonal antibodies. So the step-up therapy is you start with the aminosalicylates, which have a very good role. Then you build up with the steroids, and then you add on a thiopurine analogs, which is actually that convert. If you talk about azathioprine, that is converted into 6-mercaptopurine. So it's also kind of responsible for the suppression of the progression of the disease. And then you add the monoclonal antibodies and the anti-tumor necrotic factors. So that's a kind of a step-up therapy. So you start from simple medicines and you add on the complex one. Now, there's another approach, which is actually the top-down approach. And in this top-down approach, what you do is you start from high medicines, like you start from the monoclonal antibodies, and you gradually come to the simple drugs. Like you start from anti-TNF, then you put the patient on purine analogs like azathioprine, or you give a combination of a monoclonal antibodies and purine analogs, and then you put your patient on a steroids. So that's actually the top-down approach for the management.